Hi, this is Dr. Diane Gehart, and this is my lecture on clinical assessment that goes with my text, Mastering Competencies in Family Therapy, the second edition. Well, since the publication of the second edition, the DSM-5 has come out, and so I am updating this lecture to include DSM-5 diagnosis, and you can also find the updated clinical assessment form on masteringcompetencies.com as well as the Cengage website for the textbook if you want to start using DSM-5 diagnosis right away. And this is a lecture in two parts. This is the first part that goes over the basic introduction to clinical assessment and mental status, and in part two we're going to go over how to actually fill out a clinical assessment form. So clinical assessment is something that I recommend doing after doing a case conceptualization, which is a much more theoretical conceptualization, and it's a form of assessment, where clinical assessment is based more on a medical model, on a psychiatric model, and it is something that all mental health professionals need to do. And there are some real common standards across all the mental health professions, whether you're a family therapist, a licensed professional counselor, a psychiatrist, a psychologist, a psychiatric nurse, a social worker. All these different professionals who work in a mental health, with clients in a mental health practice have some basic things that they need to do. And these include monitoring for client safety, and so oftentimes this kind of clinical assessment is associated with, and some of the importance and why it's so standardized is that it's considered basic for monitoring client safety. Another big piece of this is kind of assessing for both medical and, more importantly, psychiatric conditions and how they relate to the treatment. And so there's something that's called a mental status exam. For short, it's called an MSE, and basically this is an exam that can be given in many different ways, in which the clinician identifies the major psychiatric symptoms that are related to the client's presenting problems. As part of this, then you make a mental health diagnosis using the the DSM manual, and in May of 2013, a new edition, the DSM-5, was released, and we're going to go over how that actually affects the writing up of a diagnosis in this workshop. And then finally, associated with all this is basic case management, and that means getting your clients connected up with community resources to help them address whatever problems that they are bringing to you. And so case management can involve kind of connecting them with crisis services, as well as evaluations for psychiatric meds or health checkups, hooking them up with support groups, working with their social workers or probation officers. Case management is a very big thing, but it is part of this broader, under this broader umbrella of clinical assessment, and something that you would naturally follow up with if you identify particular sorts of problems. So these are the basic common things that happen, and there is really a wide variety of ways in which therapists can choose to carry out these duties. And so we'll talk some about that, and a lot of that has to do with the work context that you're in. If you're in a hospital inpatient versus a private practice versus an agency, and how large the agency is. Sometimes these duties are actually broken up, where there's one person doing a diagnosis, another person's doing case management, and another team might be working on client safety, and in other contexts, the one therapist will be doing it all. And in general, therapists are expected to have a certain level of ability to do all of these things in order to function independently, which means qualify for licensure. So we will be covering those in this lecture, and of course, you know, you can teach whole classes on each one of these topics individually. In this lecture and my book is really just giving you more a basic introduction, assuming that somewhere along the line you're going to have a class on working with community resources and a class on how to do a diagnosis, and we're just kind of putting that all together and learning how to put that into a clinical form is really the focus of these two lectures. So to begin, I want to just introduce you to some contemporary issues in clinical assessment, namely the DSM-5. So many of those controversial changes were made based on the evidence. For one of the changes that had a bit of controversy behind it was autism spectrum disorder is a collapsing of 4 other former diagnoses, including Asperger's syndrome and the former autism disorder. And there was some controversy, but the evidence and the research that they had collected over the years, the general scientific consensus is that this was more of a set of symptoms across a spectrum from mild, moderate to severe than 2 distinct or 4 distinct disorders. And so they were collapsed. And there really needed to be a solid research base for any of the proposed changes that we see in the DSM-5. The other thing to note is that the DSM-5 really is an international, more of an international document. There was much more of an international effort in terms of putting it together. The revisions were actually a collaborative process between the World Health Organization and the American Psychiatric Association, and there was an international co-chair for all of the work groups that actually drafted the new criteria. 30% of each task force needed to be international, not American, basically. And so there was a real intentional effort to make this document applicable across cultures. And towards that end, the new edition of the ICD-11 will be coming out in 2015. That is an international diagnostic manual that is used for both physical and mental health in most other countries. They use the ICD for psychiatric diagnosis. And the DSM-5 and the ICD-11 are going to be much more correlated than any prior versions of those 2 documents. Now, there's been a lot of talk about the DSM-5 and pro and con and fears and hopes and all that good stuff. But I think one of the main things that's really important to understand when you hear any of the discussion about any of the changes is really getting a sense of a big picture in terms of where is mental health diagnosis going. And I think this helps frame the changes in the DSM-5 so you understand what's going on better. There is a move towards what is called dimensional assessment. And so dimensional assessment is looking at a particular psychological functioning like mood or substance use or mood stability along a spectrum from mild, moderate to severe. And we are familiar with this in the DSM-4. We had that for mood disorders in particular, major depressive disorder, mild, moderate, or severe. We're going to see a lot more of that in the DSM-5. And if you read the foreword of the DSM-5, they talk about how, in general psychiatry, psychiatric diagnosis, the research seems to be pointing us more in this direction of looking at people across a spectrum of functioning rather than trying to have very discrete categories that are clearly distinct. And there's less evidence to support that this kind of categorization of mental health and mental functioning. And there's more towards this view of dimensional assessment. And so the DSM-5 has been significantly restructured, if you were familiar with the DSM-4. And that restructuring is largely based on what the evidence base says about what we understand about the etiologies of the different disorders. So they've started grouping together different disorders based on known causes. And also this is going to allow for and facilitate more dimensional assessment as the DSM-6 and future versions roll out. So this is not going to be any radical change. I mean, it's going to be kind of moving at glacial speed. It's pretty slow. But the idea here is that, right now, what the research is showing us is that as we move forward in the future, we are more likely to see mental health diagnosis that looks like you've got moderate mood, depression, mild anxiety, severe mood stability issues, mild substance use issues, but you're going to be rating people across several realms of functioning, several dimensions of functioning, and looking at that, and even that may even allow for changes. You might get worse in one area, better in another. So a much more flexible, dimensional way of looking at functioning rather than saying you're bipolar or you're schizophrenic or whatever that might be. So for therapists working routinely with clients in outpatient settings or doing psychotherapy, family therapy, some of the biggest news in the DSM-5 is that the actual diagnosis format, how you write up a mental health diagnosis, has changed. in the DSM-4, there was a 5-axis diagnosis system that was used, and basically with us using studies on diagnosis and looking at inter-rater reliability and such, and also looking at the general evidence base for those different axes, there was no scientific evidence to really support the use of this 5-axis system. And the new diagnosis format is just what everyone else in medicine is using. It's a single quote-unquote diagnostic line. And so for this, you'd put any diagnosis 1 through 3, what was on the former axis is 1 through 3 on a single line. And then what was used to be on an axis 4 is actually going to be coded on these same diagnostic lines as a V code, or what will soon be a Z code. We'll talk about that in a minute too, as a type of a diagnosis. And for those who are familiar with axis 5, which was a global score from 0 to 100, there is no current replacement for this axis 5 global assessment of functioning, the GAF score. It's very likely the closest thing is what's called the HUDAS. It's a disability rating scale published by the World Health Organization, is the most likely closest future replacement, but the HUDAS really is an assessment for disability ratings. So there was a significant change for those used to the old diagnostic system. For those of you just learning diagnosis, this is going to be a lot easier, and you don't even know what you're missing. Now, I know some of you reading or listening to this, potentially reading the book, may not be familiar with the DSM-4 diagnosis. And even though technically, we're all supposed to be using DSM-5 here forward, it'll still be a while before I think everyone switched over to DSM-5. And in addition, you will be reading potentially old files, old clinical reports that include the 5-axis diagnosis system. So I think it's important, if you're not familiar with this, just to briefly touch on it. The first, so in the beginning we have here this axis 1 is where you're going to put most of your mental health diagnoses, such as major depressive disorder, adjustment disorder, schizophrenia. Axis 2 diagnoses was an axis just for personality disorders and mental retardation. So this, these were mental health diagnoses, but they were pulled out because they were considered more pervasive. And so this no longer exists anymore. It would just be listed along with all the other diagnoses. Axis 3 were any medical concerns and or diagnoses. And here you would, if you had access to it in your medical environment, you'd be using ICD-9 codes. And then axis 4, you wrote out what the psychosocial stressors and or environmental conditions or concerns were. And as I mentioned on the former slide, in the new DSM-5, many of these are included in the V code, or soon to be Z code section. Then for axis 5, these were where you put global assessments of functioning or global assessments of relational functioning, and this is what they did away with. And just to give you a sense of how it worked, it's a 100-point scale, and basically every 10 points they had a different criteria for that. But basically when you're working in mental health in a general outpatient or inpatient settings, 70 above were considered fully functional, not really eligible for insurance reimbursement. So these are more like numbers that you would see at discharge or termination. Then 60 to 69 were mild symptoms, 50 to 59 were moderate symptoms, and 40 to 49 were severe symptoms. And the DSM-4 did have some criteria for trying to determine that, although there wasn't a lot of inter-rater reliability. It's one of the reasons they did away with this. And then 39 and below was more, there had to be pretty significant dysfunctioning or difficulty meeting basic needs. There were serious safety issues, and often you're looking at hospitalization and very close medical monitoring when you're looking at anything below 40. So that was the old DSM-4 and DSM-3 5-axis diagnosis system, for those of you who are not familiar with it. So another thing that's not necessarily new to the DSM-5, but let's say more prolific in the DSM-5, are subtypes and specifiers. So subtypes are mutually exclusive subgroups within a diagnostic category, and these are going to be diagnosis specific. They're going to be separate numbers for each subtype. So the adjustment disorders has subtypes with different codes for each. In contrast, specifiers are much more general, and some of these new specifiers are actually used across several or all diagnoses, and some are diagnosis specific. And you will find that the DSM-5 seems to employ many more new specifiers, and the purpose of the specifier really is to alert the clinician that there are particular clinical issues that are to be aware of, and that these may warrant specific or unique forms of treatment. So for example, the new conduct disorder has a new specifier that is called with limited prosocial emotions. And so what that means is that this is a more severe form of the disorder that may need some special treatment. It's a form of conduct disorder where there's little or empathy across relationships and context. So it's a more severe form, in that this will help researchers kind of organize their research around this. It also alerts the clinician. There's another specifier for mood and bipolar type disorders, which is with anxious distress. And this is my favorite of all specifiers, because there's actually a specifier for the specifier, which is mild, moderate, or severe. But this is to say when you have someone who has maybe a major depressive disorder, but their anxiety features, and you can, instead of giving them either a new anxiety disorder, it's kind of indicating this person has depressive episodes, but there are also pretty significant anxiety disorders going along that may need a separate or distinct or clinical attention. So that's what specifiers are. Now, specifiers do not get a new code or special code. They are just written out after the name of the diagnosis to alert clinicians or members, anyone looking at the diagnosis, that there are unique features and to specify exactly what version of the disorder that they have. So another real important thing in the DSM-5 to note about in terms of how to write up a diagnosis is understanding the ICD-9 and ICD-10 codes. So the DSM-4 has has diagnostic codes in them that are actually correlated to the ICD-9. That is the diagnostic manual produced by the World Health Organization for diagnosing both physical and mental health issues. And the ICD-9 codes are basically 3 numbers, point, and then you got 2 numbers in all cases. And these were in the DSM-4. They're also in the DSM-5. And this 5-digit, all numeric coding system is related to the ICD-9. Well, in October 2014, the United States is scheduled to adopt ICD-10 codes, which have been out for quite some time. And the old DSM-4 codes, which are the ICD-9 codes, are no longer going to be valid for billing in the United States. Most other countries have actually adopted ICD-10. The U.S. is very slow in the pickup of this, largely because of the financial expense. We were actually scheduled to implement ICD-10 in October 2013, but because basically large medical systems are saying we can't make this happen, it has been delayed a year. Now, there is an ICD-11 coming out in 2015, and a lot of people were like, "Oh, can't we just switch over to that?" But apparently the powers that be have decided, no, we will not be switching over to ICD-11. We're going to do the 10 in October 2014, and these codes are all included in the DSM-5. It's in gray letters in parentheses after all of the ICD-9 codes. So come October 14, you can still pull out your DSM-5 and you will have the correct codes, but just know at that point you'll be using these alphanumeric codes that have a letter, then 2 digits, a point, and usually 1 digit. Sometimes you'll get a couple more digits after that. And that's what the new codes are going to be looking like in October 2014. Okay, so how are you going to write up this DSM-5 diagnosis? I've just kind of actually given you all the different pieces of information you need to know. And so now we're going to look at what it's going to actually look like when you put it into a form. And the form that I'm using is the revised clinical assessment with DSM-5 changes that goes with the textbook. And so this is what the prompt actually looks like. You put the code in, and then you're going to write out the diagnosis with the specifier. So here's an example DSM-5 diagnosis with ICD-9 code. So this will be good through October 2014. Or if you're looking through old files, this is what it's going to look like. So you'll see you have your code, and then you're going to write out the diagnosis with any specifier. So here we have major depressive disorder, recurrent, moderate, and then here we have the new DSM-5 specifier, the one that has the specifier, with mild anxious distress. So then you move, and so you see these 5 numbers. These are not axis numbers. These are actually just the number for each of the diagnoses. So the second diagnosis is a PTSD. So you have the PTSD code. Then it's written out post-traumatic stress disorder, and then you have a specifier with delayed onset. The next 2 codes are V and Z codes, or V codes. We'll get to the Z codes in a moment. For the equivalent of what used to be on some of the GAF scores. So here we have the V15.41, which is personal past history of sexual abuse in childhood, and then we have this 4th diagnosis, the V60.1, is inadequate housing, and that was something that would have been on axis 4 in the past. So this is what the DSM-5 with an ICD-9 code looks like written out. Okay, so here we are with the fabled DSM-5 with ICD-10 codes. Okay, everyone's been waiting to see it. So this is what it's going to look like starting October 2014. And basically you'll see again here there is a code, the F33.1, and it's major depressive disorder, recurrent, moderate with mild anxious distress, exact same diagnosis. And then you have F43.10 is the post-traumatic stress, and you can see there's some extra digits after the point there. And then we're going to move into Z codes. So there's a Z code for the past history of sexual abuse, and then there's a Z code for inadequate housing. So this is the exact same diagnosis written out with the new ICD-10 codes. So now I also want to touch on some other contemporary issues related to diagnosis and clinical assessment. The DSM-5 is not the only major change in the last few years. I also want to talk a little bit about recovery-oriented mental health and parity diagnosis. So the recovery model is a relatively new model for use in mental health. And it is parallel. Many people have heard of recovery related to substance abuse, and it is a parallel movement. It is a consumer-based movement, meaning it's led by consumers and families with persons being diagnosed with severe mental illness. And it's an alternative model that really focuses on facilitating and promoting the client's psychosocial functioning more than just treating a mental illness and reducing symptoms. So it's very much focuses on the functioning of the person, so whether or not they can hold a job, maintain their relationships, and live a satisfying life, rather than focusing on whether or not we've reduced their hallucinations or bipolar mood swings. So it is a consumer-led movement that really focuses on psychosocial functioning more than reducing symptoms. And it is an international movement. In fact, Europe, Australia, New Zealand are ahead of the U.S. in implementing it. Officially, the U.S. Department of Health and Human Services adopted a paradigm of recovery for all publicly funded treatment of severe mental illness in the U.S. in 2004. And the recovery model is being implemented slowly across the U.S. Things move slow here, glacial speed, kind of like our diagnostic codes, and the metric system is very slow to, and similarly here this is slow, and a lot of that just has to do with the financial funding. In states like California, where there has been significant funding put behind the recovery model, it's much more developed, and in other states where there's less funding, it is still being talked about because the U.S. Department of Health and Human Services talks about it, but may not be as widely implemented. So the U.S. Department of Health and Human Services in 2004 actually did issue an official U.S. definition of recovery, which is a journey of healing and transformation enabling a person with a mental health problem to live a meaningful life in a community of his or her choice while striving to achieve his or her full potential. And so as you can see here, the de-emphasis is on diagnostic labeling, and the real focus is on promoting psychosocial functioning. And how this may look and where this may be different is that in the past there was kind of an assumption, well, until all the symptoms are under, managed, well, the person shouldn't be out looking for a job. Or there was also a period of time where we did a lot of institutionalizing someone with severe mental illness and moving them away from their communities of support and their families. And in doing so, also, some would say, disrupting their life unnecessarily. And so the focus is instead trying to help people diagnosed with mental health problems determine how best to live their life, support them in achieving their goals, rather than basically the medical and mental health community defining those goals, and saying things like, well, if you aren't taking your antipsychotic medication, I won't work with you. That has been considered, at least through this movement, based on consumer report. I mean, the consumers who led this movement were feeling very abused, and that is the term that they did use. Some of them have used, there are organizations about being a survivor of the mental psychiatric, treatment systems. So there are some definitely strong feelings from these different perspectives. So the focus here is really supporting the client on their journey of healing, rather than us dictating what they have to do in order to get services. Now, as part of the official adoption of a recovery-oriented approach to mental health in the U.S., there were 10 fundamental components of recovery that were identified. The first is recovery-oriented mental health treatment should promote self-direction, meaning that clients or consumers should be empowered to be the primary decision makers in terms of how they're going to approach their recovery, rather than it being dictated by professionals and institutional policies. The treatments should be individualized and person-centered. And here they're not referring to Carl Rogers' person-centered therapy. They're talking about that the road to recovery and approach should be focusing on the whole person, not just the illness focus. It's person-centered versus illness-centered. And that these journeys should be very individualized and focused on this person as a whole. Empowerment is very important, empowering people diagnosed with severe mental illness to make decisions, to make choices, to make changes in their lives, and to support them in becoming independent. Another principle is holistic view of the person. So we're looking at the whole person in terms of their physical, emotional, spiritual, relational, whole self, looking at their work life and their contributions to society, meaning the whole enchilada. Nonlinear is another principle, is understanding that the road to recovery is 2 steps forward, 1 step back, 3 steps to the side. And that's about how it goes. And if you work with this population, that will make more sense in terms of it is not linear, and understanding, and for the professionals to be aware of that and working with clients through this nonlinear journey. An emphasis is really strengths-based in terms of focusing on client resources, strengths, and abilities, much in the way solution-focused therapists, solution-based therapies would be working with clients. There's a whole component of what's called peer support, and what this means is that people who are well on their way in the recovery from mental health, so this is someone who had been diagnosed maybe with schizophrenia, maybe still is, but is out holding a job, has meaningful relationships, feel connected to society. That's a peer who can become a peer mentor to others starting the journey. And so this is something that is used quite frequently in substance abuse, and it's also used in recovery-oriented work for mental health. There's also a real emphasis on respect of the whole person and respecting the client's perspective and voice, desires, wishes, and needs, as well as that of the families. Responsibility, and there's a real emphasis on holding persons diagnosed with mental illness. They are still responsible for making good decisions in their lives, for taking the lead in their recovery. And then hope. Finally, there is hope, and that is in many ways, this is something also that solution-focused therapists talk quite a bit about. In recovery, they talk a lot about it too. And in some ways, it is on one of the jobs that a professional does do, if they're not making all the other decisions, is fostering hope in the client that recovery is possible, that they do have strengths, they do have resources, and they can do it. And so a lot of what the professional ends up doing is helping the client develop a rationally based sense of hope. You don't want to give them, kind of hope that's not grounded in anything, but there is hope for people with severe mental illness. And it's important that therapists working with this population educate themselves about outcomes, and which are more hopeful than many of us think, and foster that hope in our clients. And another important development in the area of diagnosis and clinical assessment is parity diagnosis. And it's important to understand the difference between parity and non-parity diagnosis. So parity diagnosis refers to any mental health diagnosis that has been identified as one that insurance companies are required to reimburse in a way that is similar to physical diagnoses. So this is very important when you're actually billing third-party payers in terms of whether or not your client gets diagnosed with a parity or non-parity diagnosis. Because for certain insurance companies and in certain states, it's going to make a bigger difference than others, but that these diagnoses are going to be reimbursed differently, and to understand how to, what the politics around these are. So often these, and so most of the parity diagnoses, there is sufficient research to show that if these are not treated, that there are serious health implications, and so that is why they've been deemed parity diagnoses. So these typically include, and each state can work on its own specific list, anorexia and bulimia, bipolar, major depressive disorder, obsessive compulsive, panic, pervasive developmental disorders, schizoaffective disorders, and schizophrenia, and any disorder with a child. So these are just important to be aware of as you start doing diagnosis with third-party payers. So now that you've gotten an introduction to the actual diagnosis, I want to take a step back, and before we go any further, to also look at some of the identified, both the benefits and potential dangers of diagnosis and clinical assessment. And family therapists, postmodern therapists, humanist therapists, these are three of the major schools, many of which are talked about in this textbook, that have concerns about how the diagnosis process actually impacts the change process and the client's identity, and how they identify dangers in the process of diagnosis that it is generally required in the larger medical community. So it's worth taking some time to discuss and consider some of the pros and cons. So in terms of the benefits of clinical assessment and diagnosis, some of these are quite apparent, which we've sort of touched on earlier in this lecture. But first of all, diagnosis can be helpful in identifying potential courses of treatment, especially as we have more evidence-based treatments for specific problems or specific populations. Diagnosis can be very helpful in considering whether one of these might be appropriate. Diagnosis is also can be helpful in understanding and just kind of alerting clinicians as to how best to keep clients safe and or the public safe. And so knowing that when you have someone who's going to qualify for a major depressive disorder, that there is a potential for self-harm and suicidal ideation. And so to consider that, and sometimes having that diagnosis kind of clues someone in, yes, I should ask these questions too. And then, of course, also diagnosis can be helpful in determining whether or not referrals might be needed. With certain diagnoses, you might want to send them in, or as part of that process, you may refer a client out for either a medical or psychiatric assessment to help in that process, and or referring out for support groups for certain disorders. It's known that certain types of group work is particularly beneficial. So diagnosis can be very helpful in terms of helping you figure out where to go and what to do, especially in terms of keeping clients safe and connecting them with community resources. So in terms of some of the potential dangers of clinical assessment and diagnosis, there are many critiques of the whole diagnostic labeling process. And part of the problem with the process as it is now. There isn't like a medical test that you can just go and take and determine whether or not your child has ADHD or you've got major depressive disorder. Mental health diagnosis, almost always, at least at this point, they're working on finding biomarkers for all of this, for as many of these as possible. But at this point, and for a while further, most mental health diagnoses require a therapist to look at a person, to look at another human being and determine whether or not they are normal or not normal. And as you can imagine, when you frame it that way, there's a lot of potential ways that this can go wrong. And because every therapist who is doing a clinical assessment is looking through their own lens of what is normal and what is not normal. And this is very much colored by our culture, our values, our gender, our history, our beliefs, what part of town we live in, who our friends were when we grew up. All of these things actually come into play. And there's no way for a therapist to actually remove that lens, because everything that we see is actually a reflection. The words that we use to describe another person reflect our vocabulary, not that other person's, internal world, or even their external world. And so our descriptions of other people always reveal more about how we construct the world and how that other person constructs the world. And so it's important for a therapist to be aware of their biases and to continually cultivate an understanding of their own biases so that you can hopefully minimize this. And this is a very difficult thing to do, and it takes a lot of discipline. Most people think, well, I'm not judgmental, I'm an open person, so I'm not, balanced, I'm not biased, and I'll be a fair judge. And I think the more honest you are about this, the more you look at the subtleties of human interaction, this is difficult. And for example, I come from an immigrant European family. My mother is Greek and my dad is Austrian. And because of that, though, we certainly have much more, I would say, Mediterranean-type boundaries. And so that looks and feels normal to me, that sense of people being connected and involved. And so if we're looking at, in terms of like structural boundaries here from structural therapy, to me, my family, I think we're more, it's fairly healthy range, I hope, but still more on the enmeshed side. And when I look at other families that might be have a lot more distance, value a lot more independence of its members, like they can just go have holidays in different places. For me, that looks and feels kind of weird, because that's so different, from my family where let's get 20 people around a big table and have dinner together, and it's not a holiday unless everyone's there and it's loud and there are people and there's food, and that's just, what it looks like to me. And so there's just a wide spectrum in terms of especially how families can function and how boundaries can be. And based on your personal background and the other, the types of people you've been exposed to in your life, another way of being healthy in the world can look very dysfunctional to you just because of your own background. So it's very important that you continually monitor. This is an unending process. You never get to a point, I don't care if you're from a diverse marginalized group or not, that it is an unending process, no matter where you come from, to become more and more aware of your own biases and to reduce their effect on how you view other people. And so because of this, when you start looking at what's normal or not normal in terms of the diagnostic process, you're always bringing your lenses, your experience, your values, your culture, your gender, your sexual orientation norms to the table, and it takes a lot of discipline to not have that affect what you're seeing. Now, in terms of the theories described in this book on family therapy, systems therapists have historically had a very distant relationship with the DSM and diagnosis, and they have actually seen that, or have a lot of concerns about how diagnosing one person that they would call the identified patient can have a negative effect on actually the change process, especially from a systems perspective. Because when you diagnose someone as the problem person has a mental health disorder, then the family kind of feels like, oh, they're off the hook. I don't have to do any changing because this, my son has ADHD or my husband has depression, so it's not me, they're the two people who need to change. I don't need to do anything. And obviously, you can imagine in family therapy sessions, that's not going to really help the change process. And in fact, a systemic family therapist would say that a person's quote-unquote mental health disorder or set of symptoms actually plays a role in maintaining the family homeostasis. And which we'll go more detail into if you haven't hit that chapter in the book yet, but that there's a reason that these particular symptoms are in this particular family. And so they try not to pathologize the person or the family, but look at how those behaviors make sense in this system and how can we reorganize this system, restructure this system so that those symptoms are no longer necessary. So that is how the systemic person sees diagnosis. So their concern is that when you start going around labeling people, A, you make it seem more real than it is, and B, you make it harder for the change process to actually happen. So the postmodern family therapists, solution-focused, narrative, collaborative, they also have a lot of concerns about diagnosis and how it affects therapy, the change process, and even the identity of clients. And so from a postmodern perspective, the problem with using diagnostic labels is that many clients will take this on and it actually makes the problem bigger rather than smaller. So rather than just feeling kind of blue or out, oh, I have major depressive disorder. Oh my goodness, all the commercials on TV tell me I need to be on medicine. Oh my goodness, this is a big problem. I'm going to have to, work on this for a long time. And so often it gets people into a place where they don't connect with their resources, strengths, and abilities. They feel that the burdens actually become heavier and that the problem's even bigger and harder to work through. So instead, from a postmodern perspective, there's really a preference for client-generated descriptions of both the problem and the identity, because those can be developed in ways that it's easier to solve the problem and or to inform a more preferred identity. So from a postmodern perspective, diagnosis is a problem because the descriptions are not coming from the client. They're not framed in a way that they're facilitating change. So, and in fact, narrative therapists often use externalizing of the problem to facilitate problem resolution, and or they use descriptions that make the problem easy to solve. So instead of saying I'm blue and depressed, I'm not doing the things that I used to do that were fun. So which one's easier to solve? Let's think about that. So obviously this, I'm not doing what I used to do that made me happy becomes a much more solvable problem. So postmodernists are very skeptical and have concerns about using diagnosis in terms of the effect that it's going to have on the client and or his or her identity and or actually the change process itself. So where does this leave us? So for trying to think about from a general perspective as a family therapist who's most likely working in a work context where diagnosis is used, how can you approach this with a sense of competency while also being sensitive to how diagnosis might affect the therapeutic process and clients' identities? So one way to look at this is that diagnosis becomes one of the many possible truths out there that may or may not be useful in terms of the counseling process or the therapy process. So, for example, major depression might be one way to describe what's going on with the client. It may also, being sad or blue might be another descriptor, and or the client, might find that saying, I'm not doing what I used to do, and that's the problem. So using diagnosis, but seeing it not as, I must construct all my therapy and interventions around this diagnosis, that is one of many possible ways of describing what's going on in it, and to explore whether or not that description is useful. Because there are times where I've worked with clients, most notably with post-traumatic stress disorder, a lot of clients find that a liberating diagnosis to know that, oh, I'm not totally insane and crazy, and that this is, when you look at the prognosis for PTSD, it's actually much better than most people would think, given how severe the symptoms can be. So oftentimes, so some people do find diagnosis liberating. And so to see diagnosis as a voice in the conversation rather than a dictator of the therapy process. And so looking at how these truths and understood are contextualized by the webs of relationship and social discourse around whatever clients are talking about. So what does depression mean or anxiety mean within a particular family or culture? And how are they understanding those symptoms from their cultural background or family tradition or whatever that might mean? And to look at what is the most useful way of understanding what's going on. And so this can allow for a range of possible in-session uses and possible ways to describe the problem and finding one that fits with a particular client and from how they're seeing things, how the family is seeing things, from within a cultural perspective, as well as looking from the theoretical perspective, how best to conceptualize what's going on. And so for a general, to kind of sum up, as a family therapist, a diagnosis is one of many descriptions rather than the driving force behind the treatment. So next, I want to talk a little bit about formal and informal clinical assessment, so ways to go about conducting your clinical assessment. So in terms of looking at written clinical assessments, there are some these are pen and paper tests that are standardized. They're generally considered to be more accurate, and they can be especially useful when you have more severe multiple symptoms, you're trying to make a differential diagnosis, and or if clients haven't been responding to treatment. And so you can use these written assessments to help you with in these sorts of circumstances. And there are many formal assessments such as the MMPI, which is typically not used in outpatient treatment, but something more like a Beck Depression Inventory or the MASS for alcohol screening. So there's several different types of these written assessments. However, there is actually no clear link to necessarily improved outcomes by using some of these measures, but many therapists nonetheless find them helpful in terms of helping them make differential diagnosis, making their doing their clinical assessment. And I think you also want to consider whether or not these forms are kind of facilitating you in your work. If you're working from an approach where you want to avoid the labeling of one person as the identified patient, then these may not be helpful. And so that's something to also consider. Another thing to consider is whether or not the instrument you're using is actually normed for the population you're using it on. So if you work with very diverse clients, you may need to consider whether or not you need to research whether or not the particular instruments you hope to use are actually appropriate. Now, in terms of pen and paper measures that are available, there is a brand new set, and there are quite a few of them, that come with the DSM-5. And this is something that's totally new, that with the DSM-5, the American Psychiatric Association has made available on their psychiatry.org website and also on the DSM5.org website. These several assessment instruments, and the most important of which for our diagnosis process is the cross-cutting assessments. And cross-cutting symptoms are symptoms that are relevant to most psychiatric disorders such as insomnia, mood, anxiety, irritability, these sorts of things. And there are also adult measures and child measures. And these cross-cutting symptom measures are broken into a level 1 measure, which is the first level, and then there's level 2 measures. And in the level 1 measure is basically assesses adults on 13 domains and children for 12. And it's a relatively brief, there's only 1 to 3 questions, I think it's 36 questions in all, symptoms for each domain. And these just give the clinician a broad view as to what are the areas where the client, in what domains of functioning is the client having some problems. And so this allows the clinician to get a good sense of where to ask more questions and follow up. And so the level 1 measures are something that you would give to your client, before they walk in for their first session with their big stack of intake paperwork. And you can give them this level 1 measure and use it in your initial assessment sessions to get a sense of what might be going on clinically with them. And although these are certainly not required, they are optional measures that are published through the APA, it's likely that many insurance companies or other agencies will be using these more widely in the future. We've never had anything quite like it, but the expectation is that these will become more widely used. So in terms of the actual domains, here you can see the adult level 1 cross-cutting symptom domains: depression, anger, mania, anxiety, somatic symptoms, suicidal ideation, psychosis, sleep, memory, which is not on the children's list, repetitive thoughts and behaviors, that would go with OCD, dissociation, which is not on the children's, personality functioning, which is not on the children's, and substance use. So for the child level cross-cutting symptom domains, you have somatic symptoms, sleep, inattention, which is not on the adult, depression, anger, and irritability, which is not on the adult, mania, anxiety, psychosis, repetitive thoughts and behaviors, substance use, and suicidal ideation and attempts. So these are the general domains of functioning, and of course there are different instruments for children versus adults. Now, in addition to pen and paper measures, a lot of clinicians, or I guess virtually all clinicians, would also rely on what is a more informal clinical assessment. So these are going to be more self-reported, and these can be both either written and or verbal, where the therapist is kind of adapting these, if they're written, to kind of collect things in a language that fits more with their theoretical approach, yet covers some of the clinical issues. And so these more informal assessments can be more appropriate with diverse clients because you can adapt them. They're obviously less expensive. There's less time required. But the cons of these types of more informal instruments and or interviews is that you may not capture more subtle clinical issues. And in large measure, their effectiveness is determined by the therapist's skill. And of course, the self-report of a client may not be as accurate. And so that's also something to be considering. And I just want to mention here, because the book covers this in more detail, but that when you're going to verbally be talking to clients about clinical assessment or doing a clinical assessment verbally, it's really helpful if you can try to integrate it with whatever theoretical orientation you plan to be using primarily in working with the client. And so in the book, I have identified specific questions, whether you're working from a systemic or postmodern approach, that actually uses techniques within those theories to help gather clinical information. So if you're working from a systemic approach, you can use the techniques for mapping out the interactional sequence around the problem to identify clinical symptoms. So typically when you're doing mapping out and assessing the interactional sequence, person A says or does this, then person B does this, A responds, B responds, and then we check in to see how C, D, and F respond. So as you map out who's doing what, you can ask about, so what are the thoughts and feelings, what are the moods, what are the behaviors, and to also ask about the clinical types of symptoms that are involved around the sequence of behaviors around the problem. Also, using circular questions can be very helpful. So circular questions are used by systemic therapists, and these can be comparative questions in terms of you can be comparing moods or behaviors, rank ordering moods and behaviors, thoughts, those sorts of things. So this is detailed in the book, but I just wanted to draw your attention to it. Similarly, if you're working from a postmodern approach, there are certain interventions that can be used to also get a clinical assessment while still working within identifiable techniques in the kind of the spirit of your theoretical model. So in narrative therapy, there's something called mapping the influence of persons versus problems. And this is a great way to get a ton of clinically relevant information for making a diagnosis while still moving forward and working as a narrative therapist. So when you map the influence of the problem, you look at all the ways that the problem has affected the person's life and relationships. And so in asking these questions, you can ask about mood, thoughts, behaviors, how other people, relationships, and how they're functioning in all the different realms. And then you can map the influence of the person. So how does the person influence the symptoms and the problems. And so to ask about, and then you get a sense of the severity of the problems in terms of how the person is able to actually manage their symptoms. So this is these ways, like I said, are described in more detail in the book, and it's a way to do a clinical assessment that's going to resonate and be more true to the some of the theoretical models described in the book. So this is the end of the part 2 of the end of part 1, and I will be going into part 2, which will show you how to step by step fill out a generic clinical assessment form.